And I'm sure today's very learned moderator, Dr. Anjulakshi, will be able to put light on this very complicated issue, which is though decreasing, but is still there with all of us and our experts, Dr. Ajit, Dr. Venkateshwar Rao, Dr. Hema, Dr. Kritika, Dr. Meena, Dr. Tamil Selvi, and Dr. Rashmi Ajit, and Professor Ashok would be sharing their insights into this complicated problem. And I'm sure everybody will get benefited from it. And our dedicated coordinator, Dr. Padmaja, Dr. Manisha, and Dr. Shruti, together they have always been working behind the scene and giving the final shape to the whole program. So I welcome each and every one of you and the give to the MOC. Over to you, Manisha. Padmija, you can take over. I can't see Manisha.
Yeah. Welcome to this CC webinar series, which is the brainchild of Dr. Anju Soni Madam, bringing us from all over the country together on one platform, sharing and meeting again. It's nice to see Dr. Ajit and many more friends that are there. Dr. Anjulakshi, who is conducting this panel, has lots of accolades to her credit. She has been active. She was the past president of OGSSI, founder president of Tamil Nadu FOG, and past president of DIPSI. She's worked her whole life in diabetes in pregnancy, retired from MMC, and many more credits. Dr. Ajit is President Kerala RCOG. He's worked with a lot of RCOG guidelines, and he's been a very active member of the Kerala OB/GYN Society. Dr. Venkatesh Rao is a little late. He'll be joining us. He's the president of Guntur OB/GYN Society. Dr. Hema is also with us. She runs a private hospital at Basava Chetna Maternity Home, and she has worked in Beach Candy Lifeline Hospital, Gulbarga. She was a teaching faculty. We have Dr. Kartika Prabhu, who studied in JIPMER, who's interested in high risk pregnancy care, and she's a CIMP practitioner. She's got numerous awards, including the Asha Bakshi Award. Dr. Meena, who is been a faculty in many international and national conferences. Dr. Tamil Selvai from Madurai Medical College, who's now at Trichy. Dr. Rashima, who's from Nagarcoil. And finally, all our babies go into the hands of pediatricians. So we have Professor Ashok, who's a pediatrician neonatologist from Chennai. Welcome you all to this panel, and I'm sure all of you will improve give us good take home messages that we can practice. Thank you, madam, and over to you, Dr. Anjulakshi. Madam, you have to unmute, madam.
Yes. Thank you,
Yes.
Padmaja. It is my great pleasure. The dear organizers, Dr. Anju Soni and Preeti Soni, and my panelists and my dear delegates. First of all, I am very happy to be the part of the Triple C Wisdom Series 22. And I congratulate and thank Dr. Anju Soni for this opportunity. And this topic is a double-edged sword, and it is not very frequently discussed. So I have a great knowledgeable panelists to discuss on that. And let me go, because panelists are being introduced, I'll go straight to the panel. You are able to see my slide? Hello?
No, ma'am.
No, you are able to see my slide?
No, madam, we're not able to.
Not able to. Share பண்ண பாருங்க. Share. Now slideshow. Slideshow போங்க. இங்க தெரியல பாருங்க.
Yes, madam, we can see the slide. If you can make it full screen, that will be fine. Even otherwise, please continue because we are already
getting late. Okay.
Yeah.
Sorry, because see, you have given one participant ID.
Yeah.
That I don't know where to put.
Yeah.
Kodukka.
Madam, can you make it start?
I will.
Yeah. Even otherwise, we can see, madam. You can go ahead.
Okay.
Yes, this is perfect,
So,
madam. Please go ahead.
Right. See, the chorioamnionitis is already said double-edged sword. So, it is referred to as a chorioamnionitis or intraamniotic infection. It's an infection with a resultant. Dr. Anju Soni said, no, she has briefed about the condition with the resultant inflammation of any combination of the amniotic fluid, placenta, fetus, fetal membranes, and the deciduous. This is according to the ACOG. It can occur before labor, during labor, or after delivery. Ascending microbial bacterial infection is a cause for this, and rarely it is hematogenous spread. Example, the Listeria monocytogenes spreads by bloodstream. So the diagnosis of chorioamnionitis is based on the constellation of the clinical, laboratory, and the histopathological findings. Diagnosis is challenging and it is associated with many short-term and long-term neonatal morbidity. With a timely diagnosis, broad-spectrum therapy to treat the chorioamnionitis, either before delivery or shortly thereafter, it minimizes the significant morbidity. This is a very important point because the morbidity is going to be very serious in the neonate. And it is being classified according to the diagnostic criteria, like a clinical, where there is a presence of typical clinical findings will be there. It is microbiological when the culture of the microbes from appropriately collected amniotic fluid or chorioamnion are positive. Histopathologic is microscopic evidence of infection or inflammation on examination of the placenta or chorioamnionic specimen. And another term is tunisitis. It is again a histopathological diagnosis where there is an extension of the infection or inflammation to the umbilical cord. And the incidence, if you take, it varies with the diagnostic criteria, risk factor, and the gestational age. At term, with intact membrane, the incidence is 1 to 3%, and with rupture of membrane, premature rupture of membrane, it is 6 to 10%. And it is more frequently seen in preterm deliveries and premature rupture of membrane. In preterm labor or preterm premature rupture of membrane, the incidence is up to 40 to 70%. So deliveries between 21 to 24 weeks, the histological chorioamnionitis is found more than 94%. So that is the extent of this problem. Okay, there are so many risk factors are there, and they have got a relative risk, like when the membrane is prolongedly ruptured, more than 12 hours, the relative risk is 5.8, and more than 18 hours, it is 6.9. When the prolonged labor, if it is more than 2 hours, it is 3.7, and active labor 4 times, and multiple digital examination. This is the one, where repeated pelvic examination can predispose to this chorioamnionitis. And nulliparity, group B streptococcus colonization, bacterial vaginosis, alcohol, tobacco use, meconium-stained amniotic fluid, and intrauterine monitoring and epidural anesthesia, all these predispose to the chorioamnionitis. The chorioamnionitis in a previous pregnancy may not be associated with increased risk of chorioamnionitis in a subsequent pregnancy. And although PPROM is a major risk factor for clinical chorioamnionitis, it is the infection which gives rise to the PPROM. So, with this introduction, now we will go on to the case scenario number 1. So we are going to have only 3 case scenarios, and I think we will be discussing in detail even the theory part of it, because we rather study well. Okay. So the first case is 19-year-old primate. She presents to the casualty with a history of 9 months amenorrhea, and she is post-dated by 8 days. Complaints of pain, abdomen, and fever since morning. Dr. Ajit is there?
Yeah.
So you now tell me, how will you proceed? She has come with the post-dated pregnancy, pain, abdomen, and fever. So any other history you want to know? Or you
Thank
tell
you.
me, what are the
Thank you,
things we
Anjalaksmi
have
madam,
to
for
do?
this question.
Ah,
And actually, she's a quite young lady, nulliparous lady, postnatal
Yes.
pregnancy,
yes.
coming with pain, abdomen, and fever. So you have to think of some differential diagnosis like amniotic infection, that is what we say the chorioamnionitis. Another possibility is other infections like urinary infections, respiratory tract infections. Then can be a gynecological problems like a red degeneration of the fibroids, or even a surgical problems like acute appendicitis or cholecystitis. So we need to take a detailed history from the patient, especially we have to ask about any leaking, any sexually transmitted infections, any urinary symptoms, any respiratory symptoms. So a detailed history is very important. And again, the examination of the patient, the general condition, the actual temperature.
So in the history,
the
one
vitals.
second, Dr. Ajit, in the history, when they give a history of ruptured membrane, the very important thing is how long she is
if there is a
leaking, how long she is
definitely you have
leaking,
to ask about how
and
long it
whether
it
she
is
has
for
gone
medical
to any other
examination.
hospital where they would have done a PV and all. So that history also
very
we have to ask. Yes. Okay.
Even in the examination of the patient, looking for any abdominal tenderness, any uterine tenderness, then as we discussed, maternal tachycardia, fetal tachycardia, fever, then a specular examination for a foul-smelling discharge or a leaking pervagina or a bleeding, because this patient is having fever, abdominal pain, can be an abruption, and fever may not be related to that. So a detailed examination is very important for this patient. Again, relevant investigations like doing a complete blood count.
We will go to that later. We will go to that. A little theory we will discuss. There are different categories of intraamniotic infection. Dr. Venkateshwar Rao, he is there? Dr. Venkateshwar Rao is there?
Sir has not yet joined, madam. You please.
Okay.
Can
So
ask.
Dr. Ajit, you can answer?
Yes,
Okay,
madam.
okay.
I have
Yes.
joined.
Venkateshwar Rao.
Yes,
There
good
are
evening, madam.
different. Good evening. How are you?
Fine,
Welcome,
madam.
Okay. We are friends. We have met many times during the
Yes,
exam.
madam. That's why I joined.
Okay. So for you, the question is, there are different categories of intraamniotic infection. Can you name that?
So there are actually this chorioamnionitis is a challenge, very difficult to diagnose.
Yes.
And the categories are isolated maternal fever, only fever, or suspected intraamniotic infections, or confirmed intraamniotic infection. In case of the isolated maternal infection fevers, there will be a rise of temperature of 101 or 39 degrees centigrade single time, or a temperature of 38 to 38.9 degrees that persists even after 30 minutes.
So one reading more than 101.
101.
101, we have to think in terms of chorioamnionitis.
Chorioamnionitis.
So when it is less but persistent, again the possibility is there. Okay.
Yeah.
Right. Then
so
actually in the clinical scenario, people may come not with the tenderness of the uterus, they may come with the fever alone. So that's why the temperature is very important. When it is 101, you think of chorioamnionitis, or it is a persistent fever, think of chorioamnionitis. Okay. So actually, when will you suspect the intraamniotic infection? Dr. Rashmi? Dr. Rashmi is
Yes,
there?
madam.
Yes.
Yes, madam. I'm there, madam. Madam, when there is a maternal fever, if there is an increased CRP or the maternal leukocytosis, or
Clinically,
there is some purulent,
Okay, proceed.
or if there is some purulent discharge, clinically there is some discharge, or if there is a fetal tachycardia or a ready fetal pulse, all this you have to suspect in amniotic infection.
Okay.
And also the other methods of confirming it is probably only after doing a amniotic fluid testing, culture of the amniotic fluid.
Okay, so what other things you can test in the amniotic fluid? One is culture.
Or you can
look for the organism by gram staining. You can look for the organism by gram staining, and also glucose level in the amniotic fluid, which will help. Okay, but here you have to remember, in diabetes, the values will be high. Okay, so that part you have to remember. Normally it will be less in diabetes, because even there is hyper blood sugar level in the amniotic fluid will be high. So that you have to remember whether she has an associated diabetes mellitus. And confirmation is with the, of course, placental
even
pathology.
you can go for a placental placental biopsy can be taken.
So finally you can say whether she had a chorioamnionitis or not with the histopathological examination. Okay. Next, Dr. Hema. There are many names for this chorioamnionitis. Can you list that name, Dr. Hema? The Hema is not there. Dr. Venkatesh Rao, you can answer. Dr. Venkatesh Rao?
Yes, ma'am. Yes, ma'am. The other names for chorioamnionitis is intraamniotic inflammation or intraamniotic infection, or otherwise called as triple I. Triple I.
Triple I is intrauterine, intraamniotic infection or inflammation. So it is called triple I, intrauterine, intraamniotic inflammation. Okay, or intraamniotic infection. Okay, yeah. Good. So now, microbiologically, what are the organisms that are involved to cause this chorioamnionitis?
Madam, I'm here. Dr. Hema.
Yes. Hema, you can answer, Hema.
Yes, madam. Am I audible?
Yes, audible.
Yeah, madam, it's usually polymicrobial. Mainly bacteria may be involved, or mycoplasma may be involved, or many other organisms. It depends on the location and specific population. Common ones are group B streptococci, which contributes to 15%. Then bacteroids to 30%, E. coli, Gardnerella vaginalis, Mycoplasma pneumonia, Uroplasma, Candida, and its subspecies. Even genital mycoplasms like Uroplasma urolyticum, Mycoplasma hominis are very common, especially they are found in the lower genital tract, and 70% in the upper genital tract.
No. They are present in the lower genital tract.
Lower genital tract, and rarely in the upper genital tract.
Okay.
Others, some gram-negative rods or enterococci and anaerobes may be present, madam.
Okay. So there is a terminology called aerobic vaginitis. What is it, Hema?
It is different from the bacterial vaginosis, madam. It represents a strong host immune response to the aerobic vaginal flora, especially this group B streptococci, E. coli, which is associated with ascending chorioamnionitis.
Okay. So the important thing is the host immune reaction. That's what the host immune reaction in the mother, in the fetus, gives rise to a lot of morbidities and even mortality. Okay?
Yes.
Right. Is there any chance for vertical transmission? This is usually a retrograde or ascending infection from the lower genital tract. So very rarely you can get a hematogenous spread also, which will infect the placenta. The example is Listeria. Okay? From there you can infect the fetus. And what is the pathogenesis involved in this chorioamnionitis, Dr. Kartika?
So usually, mostly infection, as we have discussed earlier, the infection is usually an ascending type of infection from the lower genital tract.
Yes.
But sometimes infection can occur by hematogenous route, as discussed, viral infections and listeria, and which can cause transplacental spread. Some intrauterine procedures which we do can also cause infection, such as amniocentesis, and rarely infection can be antegrade. So from the peritoneum through the fallopian tube also infection can spread. So the basic pathogenesis is this infection is going to produce inflammatory response. So there is both maternal inflammatory response as well as fetal inflammatory response. So this lot of pro-inflammatory cytokines and chemokines are going to be released, and this maternal inflammatory response is going to produce it is going to release the prostaglandins, so it can result in preterm labor and premature rupture of membrane, as well as it is responsible for the clinical signs and symptoms of chorioamnionitis. Whereas the fetal response, same thing, this inflammatory cytokines, it can affect the fetus and can produce neurological sequelae and other complications.
Okay. Okay. So, you can tell how it is being staged. Histological chorioamnionitis, one group you have said, no? They are being staged as stage 1, 2, 3. Can you elaborate on that?
So there will be two staging. One is for the maternal response, inflammatory response, and second is based on the fetal inflammatory response. So for the maternal response, stage 1 is when the subchorionic space is going to get involved. That is stage 1. In stage 2, chorion along with the amnion may be involved. In neutrophilic infiltration will be present. And in stage 3, there will be necrotizing chorioamnionitis. Whereas for the fetus, we see the umbilical vessels. So in stage 1, the umbilical vein is involved.
It is going to be little complicated, no? It is difficult to remember. So the staging, both for the mother and the fetus is there. So you just mention, Karthika, it's okay, mention about the
So
fetus.
in the mother, subchorionic space is stage 1. Stage 2 is when there is chorion as well as amnion involvement. Stage 3 is a severe form where there is necrotizing chorioamnionitis. For the fetal response, stage 1 is when the umbilical vein alone is involved. Stage 2 is when both, that is funiculitis occurs. That is both the umbilical arteries are also involved here. And in grade 3 is a severe form where there is circumferential inflammation around the umbilical cord.
Okay, in the cord itself, first artery is involved, next the vein, both are involved, stage 2, and then the throat, that is the whole thickness of the cord will be infiltrated with the leukocytes. Okay, Dr. Meena.
Yes, madam.
You talk about the intrapartum chorioamnionitis. What is the most reliable clinical indicator for the intrapartum chorioamnionitis?
Yes, as we know, already told, there will be maternal fever that is more than 39 degrees Celsius or 101 degree Fahrenheit. And on palpation, we'll be able to feel fundal tenderness. And there will be tachycardia, maternal tachycardia more than 100 beats per minute. And fetal tachycardia, the rate in the CTG may be above 160 beats per minute. And on speculum examination, we'll be able to appreciate the purulent or the foul-smelling amniotic fluid or the cervical discharge. And there also we do have the criteria, Gibbs criteria, which is maternal fever with 2 or 3 findings as said above. Whether it could be a maternal tachycardia, fetal tachycardia, uterine tenderness, or a foul-smelling amniotic fluid and maternal leukocytosis or a elevation of the C-reactive protein.
Good. Okay. So, Dr. Ajit, how to make a diagnosis of the clinical chorioamnionitis?
Actually, Dr. Meena has already told us. Actually, diagnosis mainly clinical diagnosis.
Yes. Okay.
That is, if there is a fever with 2 or 3 other additional criteria, we have to make a diagnosis of chorioamnionitis. Additional criteria may be a fetal tachycardia, maternal tachycardia, or purulent discharge, uterine tenderness, or even leukocytosis.
Okay.
Then, but in a patient with a PROM, such cases, there can be a subclinical chorioamnionitis. That is based on the lab investigations, like doing a CRP or leukocytosis.
So, clinical chorioamnionitis, only with the clinical findings, we can definitely make the diagnosis. So, when it is subclinical, that is in the PROM patients, we have to go for an investigation. So, we'll go to the investigations now. The clinical already you have described. Now I will ask Dr. Venkateshwar Rao, what are the
Yes, please.
investigations we will do?
So usually we'll, because it's all infection, inflammation, we'll first do the complete blood picture, and then you go for the urine routine, and then culture and sensitivity. We take a high vaginal swab for culture and sensitivity. And the other thing is, which we are not routinely being done, is the amniotic fluid sampling for bacteria and the other things.
Yes, yes.
And GPS screening test.
Okay.
Yeah.
So the GPS screening test is a controversy. They say
Controversy,
between
that's right.
Okay.
Yes,
Okay.
ma'am.
So
Whether to
at
do it
term,
routinely or not is a controversy.
so at term actually, it is the
Primarily due to clinical.
primarily it's a clinical. Primarily it is the chorioamnionitis. Okay.
Yeah.
By the clinical findings. Okay. By the clinical findings. And so already Dr. Ajit has mentioned about the differential diagnosis. So we have to remember the differential diagnosis, and suppose if we are not getting the clinical findings, then we have to go for the investigations according to the differential diagnosis. Okay. So these are the clinical parameters where the temperature more than 100.4 or 101.1, tachycardia, all these are being mentioned. And the culture showing the microbial growth. Gram stain will show the bacteria of the white blood cells more than 6 per high-power field. And interleukin, when we are in doubt, we can go for the IL-6 estimation, which should be more than 7.9, and that gives a sensitivity of 81%. And other high investigations which we are not doing in the institutions, like white blood cell count, more than 30 per cubic millimeter, again indicative of an infection. Sensitivity is 78%. But the leukocyte X-rays, which you can do by dipstick, no, that has got a sensitivity of 95 to 100%. So that is very important, which can be easily done. So we can identify the infection with the dipstick. Okay, now Dr. Reshma, what are the non-invasive techniques? This is for the theory part for antenatal diagnosis of the chorioamnionitis. It is not actually needed, but no, we will be doing some of the investigations. Just tell me.
So, Madam, the complete the white blood cell count and the CRP is probably one of the non-invasive tests.
Non-invasive technique. Okay, right. C-reactive protein. And also some people, they calculate the neutrophil and the lymphocyte ratio, NLR ratio. Okay, those are all for sepsis, any sepsis. Even during our COVID time, we were, to know the severity of the infection, we were doing the NLR ratio. Okay, so that can also be done. So CRP and other serum markers. And Dr. Hema, now
Yes,
you
sir.
tell me, what is the role of ultrasound in diagnosing the chorioamnionitis?
Madam, we usually do the fetal well-being and check out for the gestational age.
Okay.
And we assess for the fetal thymus perimeter and the transverse diameter. And this has demonstrated to predict chorioamnitis in patients with clinically diagnosed, especially PPROM, premature rupture of membranes.
Okay. See, actually, that the thymus diameter, no, it indicates the fetal immune reaction.
Yes,
So when
yes.
there is a fetal immune reaction, that means there is infection. So the
Yes.
indirect evidence. Okay.
Right. Less than the 5th percentile, madam.
Yes. Okay. So now the Kartika, already this question has been answered. To briefly go through the differential diagnosis.
So any antenatal patient with pain, abdomen and fever. So the first diagnosis we will be thinking about chorioamnionitis, but the other causes, that is urinary tract infection, those things also should be thought of.
So you can classify them, like when there is a pain alone without fever, fever alone without pain. So like that you tell Kartika.
So pain with fever, we should think of acute appendicitis. Second, red degeneration of fibroid. Suppose fibroid complicating pregnancy is there, that also can present with pain and fever. And urinary tract infection will also present with pain and fever. And other things which have only fever is like pneumonia, influenza, any upper respiratory tract infections. And pain abdomen alone may be a feature in case of abruption. So there may not be fever. So patient will be pregnant with the pain abdomen, but when you examine, you'll be able to elicit uterine tenderness and tone of the uterus will be increased, which will suggest that there is abruption. And some other pain alone may be a feature in case of thrombophlebitis, colitis, and other connective tissue disorders also.
So when you examine, you have to remember all these differential diagnoses, and accordingly, you have to examine and get the findings. Okay, Dr. Tamil Selvi.
Madam.
We were telling, no, this chorioamnionitis is having maternal complications and the fetal complications. Just explain about the maternal complications.
Because of the infection, madam, the patient won't get the contractions properly. So usually we get prolonged labor in this patient. And because of the prolonged labor and because of the inefficient uterine contractions, there is increased risk, increased incidence of cesarean delivery, 2 to 3-fold increased incidence of cesarean delivery. And due to the infection of the endometrium and the myometrium, the patient will go for endomyometritis and pelvic abscess. There is a risk, but in this era, we overcome this. And because of the inefficient uterine contractions and uterine muscle contractions are not proper, the patient is at increased risk of postpartum hemorrhage, madam. Postpartum hemorrhage.
Yes.
With the advent of antibiotics, we are dealing with the infection very well nowadays. But if it is not attended to, if it is in a very bad shape, we go for the septic shock, madam. Patient will go for septic shock. Septic shock includes the DIC, adult respiratory ARDS. And when there is a very severe infection in a very big sepsis and pelvic abscess, there is a need for hysterectomy. And a very, very sad situation of maternal death can occur in chorioamnionitis if it is not attended to properly, madam.
So nowadays, no, it is very rare, actually.
Very rare. It is not very rare.
Okay.
It's not common.
Right. Dr. Venkateshwar Rao, what are the fetal complications?
Yes, madam. The fetal complications may be a short term or a long term, and even the fetal death and the fetal growth restriction will be there. And the fetal response to infection, it will be the syndrome is called fetal inflammatory response syndrome, where it involves the eye problem, lung damage, or even cerebral palsy, a long-term problem will be there. And these are all the responses due to the inflammatory response, fetal inflammatory response.
Okay, right. So actually the histopathological, if you want to know, the punicytis and chorionic vasculitis. As Karthika was telling, inflammation.
Yeah, inflammation of the cord,
umbilical artery and the vein and surrounding collagen. Okay. Dr. Ashok. Now,
yes,
pediatrician, your role. So
yes,
first tell us about what is FIAR.
Yeah, thank you, ma'am. So just fetal inflammatory response. This is just similar to any systemic inflammatory response we will have in adults or any class. That is similar, whatever baby that fetus is showing, that is a fetal inflammatory response. So yes, already sir told, Venkat sir told, the actual definition is based on cord blood interleukin 6. If it is more than 11, the diagnosis whether there is a high possibility of that fetal inflammatory response, that is FIRS is there. But the key thing is many times it may be just an inflammation and a bacteremia may be there, or sometimes bacteremia may not be there. So that all the inflammatory mediators, interleukins, tumor necrosis factor, all this may cause further damage to the baby. So mainly it may involve the lung, the brain, and the eyes. So that is the main thing. And the main thing is it can predispose the baby to preterm labor, and the complications of prematurity can be there. So most likely organisms, as we discussed, it can be gram positive, gram negative, but again mycoplasma and other groups are also has been involved. So it can lead to short-term complications, like a respiratory distress syndrome, pneumonia. So baby can present with respiratory symptoms. But again, that respiratory distress syndrome, some studies have shown there is decreased incidence, but majority of studies are showing the respiratory distress syndrome also is increased. The short-term complications also increased because of chorea meningitis. But there is definitely long-term, all the complications are increased. Even with the comparison to chorea meningitis, both histological and clinical chorea meningitis, there is one or two meta-analysis to support that the odds ratio is almost 2 to 3 when in preterm and in term babies also when compared to babies who are not exposed to chorea meningitis. So long-term complications, mainly cerebral palsy and neurological abnormalities all can be there because in the growing brain, especially preterm babies, these inflammatory mediators may deactivate the progenitor cells and so that cerebral palsy can be there. Apart from that, the positive infection, bacteremia, neonatal sepsis may be there, and it can predispose the baby to sepsis, shock, and just like septic shock and death also. Yes, ma'am. And the long term, the lung complications are BPD. Yes, ma'am.
What is your clinical experience, Dr. Ashok?
Yes, ma'am. In clinical experience, majority because in nowadays this may be majority are preterm. So term chorea meningitis we have seen in very rare only. Majority are preterm. Mostly they may be having short-term respiratory complications. They may be on CPAP for some time. Maybe if on ureaplasma and this mycoplasma, we will be suspecting if baby is unusually getting prolonged. Maybe because the incubation period is around 2 to 3 weeks. If their prolonged illness is there on the second or third week, also baby stuck on respiratory support, we will think whether any course of azithromycin or may be helpful in bringing the baby out. Again, definitive diagnosis, you may have to go for any PCR cultures from the tracheal secretions and all that, and or maybe not much evidence is there, but there is many meta-analysis to support that the azithromycin may be useful in preventing the long-term BPD also. So in experience, yes, majority of preterm babies, they may having some respiratory complications and prolonged illness when compared to babies who are not exposed to that PROM and other details. And long-term complications, BPD, but most of the babies may come out, may require some 3 or 4 weeks additional hospital stay for oxygen requirement. And on follow-up, yes, they may be at risk of cerebral palsy that we have to follow up in a high-risk development clinic. And so another problem also because
have you seen a cerebral palsy in the follow-up of the patient? Babies?
Yeah, yes, no, if it is especially if positive infection, culture positive infection and all is there, they are at in preterm babies, they may be at risk of cerebral palsy. Yes, ma'am. But many of the times the subtle signs may be there. Majority of the babies may be able to walk and talk, not like the severe birth defect, HE, grade 3 sequelae and all, where they will be very much morbid. So these majority of the babies may have minor features like these things. And nowadays, whether these chorea meningitis are predisposing these preterm babies to other like ASD spectrum, autism spectrum disorder, or behavioral disorder, whether it is that that is again some research may be going on to this because of the genetic modulation. All this inflammation is causing them to be at risk of bronchial asthma and other things also. Yes, ma'am.
See, when you identify early, when you identify the FIR early, can we prevent this cerebral palsy? What other investigation will tell you this baby will go for cerebral palsy later on? Because cerebral palsy is a very tragic end. Okay. So whether we could anticipate that? Yes.
So one thing that for whether this baby is at risk of cerebral palsy, one, and the first question, madam, is can we identify and prevent? Again, identification, prevention is antenatal itself, the care everything has to be seen, but sometimes it may be that bacteria may not be there, but inflammatory mediators in the baby is just causing the problem, just like bacteria is gone, only the inflammatory mediators, just like COVID, everything that is causing the problem. How can we prevent early? Again, ultrasound of cranium, so that and all, and growth of the baby. How is the head size growing of the baby in the hospital stay? If any research basis and all, we can identify any MRI markers also at around term corrected age, at around 40-42 weeks, to tell, yes, any cystic periventral leukomalacia is there in the ultrasound. So those are all the markers to tell. They may be at a relative risk of around 2 or 3 times when compared to those babies who don't have those markers. Yes, ma'am. Mainly,
so
it is a
it
neurological imaging and neurological
uh,
examination at discharge at term corrected age will help us.
Thank you, Ashok. Very
Sir,
elaborately you have
Thank
just
you.
said it.
ma'am. Sorry, ma'am, one point, one question to
Yeah.
him.
Uh,
Sir, because the autism
Yes,
is
sir.
day to day is increasing,
uh,
and then psychological psychiatric problems, schizophrenia are increasing. So, and the choreoamnitis
Yes,
is
sir.
very difficult to diagnose.
hmm.
And what about the subclinical choreoamnitis causing these things? Because it's very difficult. Who should be given antibiotic? Who should not be given? Is a big challenge to the obstetrician.
Yes.
So how to take this
Yeah, yes, sir.
situation? How to?
But yeah. Yes, sir. Thank you for the question. But I think we don't have any scientific, any correct, which is correct, which is wrong at this stage. But choreoamnitis, again, studies are showing because of in vitro that changes, that it is causing the risk may be higher. But many times it may be non-infective because of their predisposition or infection in some other places that is triggering. And again, I think that is still very unclear, and more knowledge is needed for us.
Yeah. Because it's not only the organisms. Sometimes there are
Correct, sir.
some other mutagens. Everything
Yes,
plays
yes.
a role.
Thank you, Ashok, for that
Thank you.
nice
Thank you.
answer, right? So all this has been covered. So actually the long-term complications, the baby, short-term complications, baby can get a necrotizing enterocolitis, retinopathy, immune dysfunction, RDS and white matter, intraventricular hemorrhage, white matter damage. And long-term, as Ashok said, asthma, COPD, and the poor lung function. And the last one, this autism, schizophrenia, which Dr. Venkatrao was asking, is really a problem. So we have to do more studies and have a clear picture and know how to prevent these things. Thank you. So now, Dr. Meena,
Thank you.
now the patient which I have said that presented earlier, she has now in the early labor. How are you going to manage?
So generally we wait for the labor to start, madam. So she's in early labor. We need to continuously monitor her for maternal temperature. As if there is a maternal temperature, we go on to give an antibiotic, which will be a basic antibiotic like ampicillin or erythromycin. And based on the culture report, we may switch over to the sensitive antibiotic. And also
the culture report, Meena, we are going to get after 72 hours.
So by the time we'll start a basic antibiotic like oral erythromycin or injection ampicillin, madam. And after the sensitivity, we'll switch over the antibiotic. And for pain, acetaminophen, also it helps to reduce fetal acidosis and fetal encephalopathy. And
that is very, very important. So you have to stress on the point, when there is a temperature, you give paracetamol. So not only for the mother, it helps the baby, and this response will be very good, prevent the acidosis, right?
Yes.
Okay.
And first line antibiotic, along with that, if we suspect anaerobic infection, we do start them on metronidazole and clindamycin. If there is a positive intrapartum GBS positive, we do start penicillin G, madam. There are different recommended antibiotics. The main thing will be ampicillin and gentamicin. Ampicillin 2 grams intravenous every 8 hours. And gentamicin will be 2 milligram per kg IV as a loading dose, followed by 1.5 milligram per kg or 5 milligram per kg IV every 24 hours. And if there is a mild penicillin allergy, we do give them cefazolin and gentamicin. Cefazolin will be the same dose as ampicillin, 2 gram intravenous every 8 hours, and gentamicin either 2 milligram per kg intravenous followed by 1.5 milligram per kg every 8 hours or 5 milligram per kg IV every 8 hours. If there is a severe penicillin allergy, then we need to either give clindamycin or vancomycin and then combine with gentamicin. Clindamycin at the dose of 900 milligram intravenous every 8 hours. If we are going to give vancomycin, 1 gram IV every 12 hours. We need to watch for the Treadman syndrome. And gentamicin, the usual dose. And if the patient is delivered by cesarean section, following a cesarean, we have to give another additional dose of the particular regimen which we have started. And we can also add clindamycin or metronidazole if we are suspecting an anaerobic infection. And post vaginal delivery, there is no requirement for any additional dose if clindamycin is not indicated. And also in our tertiary center, we can give ampicillin sulbactam as other alternative, or piperacillin tazobactam regimen, or cefotitan, or cefoxitin, or ertapenem.
So the broad spectrum antibiotics we can start.
Yes.
Okay, right. Okay, so and if it is a cesarean section, you will give one more dose. Vaginal delivery, there is no need.
Yes,
so I will ask you later one more question. When will you give more or continue the antibiotic? What are the situations you will continue the antibiotic?
If there is a continuing temperature, the patient has to be supported with the antibiotic, madam. Puerperal period as well. She has to be continued with the antibiotic.
So how long will you continue?
Usually in normal delivery, 48 hours, then switch over to oral antibiotic. If the temperature settles, if it doesn't settle, we have to give at least for 5 to 7 days, madam.
Okay. So actually, in the clinical chorioamnionitis, if there are no bacteriological or the histopathological evidences, they are not there, or we are not looking for it, there is no need for an antibiotic after delivery if it is a vaginal delivery. In a cesarean, you give one more dose. But when you suspect a persistent infection, when you anticipate that she will have a endometritis like that, no, you have to give a prolonged antibiotic treatment. Okay. Just excuse me, there's a problem with the now. So this is about the antibiotic part. How will you manage her during labor?
Labor monitoring is usually by the partogram in the active phase of labor, using a partogram and marking the uterine contractions as well as the fetal heart rate, as well the temperature, pulse rate, the blood pressure, the urine output, fluid intake, all should be done. And usually, as already said, there can be a protracted labor, which we may have to augment by giving a syntocinon. And route of delivery will be based on the Bishop score, how she progresses. We can allow for a vaginal delivery. If she doesn't progress and there is a clinical chorioamnionitis, the puerperal fever is there, we may need to do a cesarean section. And also we need to anticipate postpartum hemorrhage, give all the measures for active management of third stage of labor, including giving tranexamic acid, syntocinon, or a carbitocin. And
the first bundle you will give. Okay.
Yes.
Right.
Yes.
So the principle in chorioamnionitis is one is antibiotic. Now the next is the expeditious delivery. Okay. So for that, no, you will not do cesarean for all cases. It depends on the Bishop score and the amount of uterine contraction, how she is responding to symptom drips, everything. So if necessary, then only you will do the cesarean section. And anticipate for the postpartum hemorrhage. Okay.
Yes, ma'am. And induction of labor and delivery for PPRM is after 34 weeks. Mainly if there is no chorioamnionitis which is progressing. Usually give a expectant management. In expectant management, we do have reduced maternal infection and need for NICU care without any increase in the perinatal morbidity and mortality. And if the prolonged rupture of membrane is more than 18 hours at term, prophylactic antibiotics not indicated if the mother is not colonized with GBS. Okay. And the Center for Disease Control recommends starting GBS prophylaxis if the GBS status is unknown. But in general, we are not giving the antibiotic if
for GBS.
Yes. And there is a randomized control trial saying use of intrapartum prophylactic antibiotic like ampicillin sulbactam for meconium stain fluid is associated with reduction in the risk of chorioamnionitis.
So one more indication for antibiotic, even in the absence of fever, tenderness, if there is a meconium stain like that, you give an antibiotic to prevent. which is going to be only till delivery. Okay.
Yes, madam.
Right.
And immediate intermittent use of antibiotic reduces the maternal and fetal complications of chorioamnionitis, and also the frequency of neonatal sepsis gets reduced when we are going to give an intrapartum antibiotic. And cesarean delivery, we have to do clindamycin every 8 hours or metronidazole
Yes.
for anaerobic coverage.
Okay, right. Dr. Kartika, what are the post-delivery recommendations? I think Meena has finished. You can tell 1 or 2 points.
So as already discussed, so if you are giving antibiotic for, usually prefer to continue postpartum antibiotics, but according to recommendations, following cesarean section, we have to give 1 more additional dose of antibiotic after delivery. For normal delivery, if they are at risk of developing postpartum endometritis, or if they have persistent fever or bacteremia, then we have to continue the antibiotics.
Okay. But now, with the effective treatment of Meena, patient is delivered vaginally and the baby was given to the pediatrician. Dr. Ashok, you are there in the situation. What are the information you want to know from the obstetrician? And also, how will you care for the neonate?
Yeah, thank you, ma'am. Mainly we will look at what are the risk factors you mentioned: duration of rupture of membranes, and the risk factors for chorioamnionitis, maternal fevers. All those details we will be noting down. So whether any fetal tachycardia was there, that also we will be looking at. So on the neonatal problems, mainly the risk of infection, any symptoms of neonatal sepsis, predominantly in early onset sepsis, respiratory symptoms will be there. Respiratory distress, tachypnea, grunting, and cyanosis, these features will be there. And hypoxia, the baby may require respiratory support and other monitor. And the shock also can be developed because of septic shock. If baby is going to shock, those things we will be looking at. Majority of them, early onset sepsis, the respiratory complications presentation is the majority. But again, it is difficult to differentiate whether it is because of infection or because of a majority are preterm, many are preterm. It is because of respiratory distress syndrome. So the management wise and all may be similar. Yes, any other respiratory distress in especially in preterm babies, and we will be looking at the vitals and keeping the baby warm, warmer care. The basic neonatal care will be there. And based on oxygen requirement and signs of respiratory distress, baby may require ventilatory support and the management with IV fluid, shock, and other things based on blood parameters like counts, coagulation profile, and we will be managing the baby. Yeah.
So you will be prepared. So they have to inform you before that, and you have to be prepared for all the resuscitative measures. Yes.
Correct, ma'am. Correct, ma'am.
Okay.
So in the majority of term babies, they may be asymptomatic also.
Okay.
In preterm babies only, many may be asymptomatic and requiring. Yes, ma'am.
Okay.
So diagnosis of early onset sepsis. Actual diagnosis, the blood culture, that is the gold standard. So we'll be looking at the blood culture or any other, so that is the gold standard that we will be following. But other, if the blood culture is negative plus symptoms are there, based on the baby's total count, whether if it is high and other markers, so we will decide on the duration of antibiotics. If culture is positive, definitely 14 days may be required. Otherwise, we will be deciding based on other things. If culture is negative and baby is improving within 2 or 3 days, the duration of antibiotics will be decided based on how is the baby improving. Majority of them, it is blood culture we will be looking at, ma'am. And X-ray, if any X-ray patch is there, unilateral, that is not with PROM, then we will be looking at, okay, so whether baby has aspirated and the pneumonia is there because of the aspirated infected amniotic fluid. But looking at ET secretion culture, that one many times we not been doing, and the CSF analysis we will be doing mainly in early onset sepsis if the neurological symptoms is there.
Only convulsions are there, you will do, or
yeah, a majority of time, yes, ma'am. If convulsion is there or baby is unexplained lethargic, then we will be looking at. But in early onset sepsis, the incidence of meningitis is very less. maybe less than 1%, majority it is a pneumonia or the bloodstream. So as such, the guidelines also recommend to do LP and CSF analysis if culture is positive.
Okay.
Otherwise, routine CSF analysis in early onset sepsis, if culture is negative, we will do only if baby is symptomatic, is lethargic and not moving and activity is not the neurological activity is not good, we will consider doing LP. Yeah.
Excellent.
Thank
Dr.
you.
Ajit. Dr. Ajit is there?
Yeah.
Now, we have talked about the treatment, everything. How to prevent this? Because it has got so many devastating long-term effects on the baby. So it is better we prevent that. How to prevent this chorioamnionitis?
We all know that it is not preventable 100%, but we can assess the risk factors. Mainly in patients with the preterm PROM, we can consider giving antibiotics. The recommendation is give antibiotics for 10 days. It helps in reducing chorioamnionitis as well as helps in prolonging the pregnancy. The usual pattern what we give is injection ampicillin we give for 48 hours along with erythromycin, oral tablet, and then we convert it into amoxicillin plus erythromycin, total of 10 days.
Okay.
Another option, especially in our unit, what we do is instead of giving erythromycin, we give azithromycin. Azithromycin plus injection ampicillin for 48 hours, and then amoxicillin for total 10 days. But in term PRIM, there is, as somebody rightly, Dr. Meena, I think, she told us there is no place for giving antibiotics unless you are suspecting a group B streptococcus. But we know that group B GBS is very rare in our setup. The prevalence in India is very low. So routinely, you don't usually go for GBS screening, and usually we don't give any antibiotic for a temp PROM, but don't go for expectant management. If it is a temp PROM, especially if it is after 3 weeks, go for induction. Then avoid multiple vaginal examination. It's very important. Each vaginal examination will be increase the chance of this patient developing chorioamnionitis. And when you are doing it, it has to be done under all aseptic precautions. So these are the way to prevent chorioamnionitis.
So one important point is avoid multiple vaginal examination. Very, very important. Okay.
Yeah.
Now, next, we have finished with the first case. We'll go for the second case. This will be just a presentation of the scenario alone. And there are no questions for this. Mrs. X, a 37-year-old lady, attended the emergency department with a complaint of white discharge PV for 4 days. It is in a private medical college. She was an unbooked case, and both patient and attendant were unaware about the current pregnancy. She was a gravida 2 para-1 live-1 post-cesarean pregnancy, and her LMP is not known, and the history is of course not reliable. She vaguely said she had 4 doses of parenteral iron given 2 months ago. The first pregnancy was 18 years ago, and it was an LSCS. That baby is alive and healthy. Now, second one, which is diagnosed as twin gestation on the day of admission. And on examination, she is febrile and pallor present, bilateral penile edema present. Her pulse rate was 132 per minute and BP 130 by 90 millimeters of mercury, CVS and RS, they are NAD. And the per abdomen examination, uterus over distended. It is acting. She is getting 3 contractions for 10 minutes, lasting for 30 seconds. And fetal parts felt, and both fetal hearts were good, and scar tenderness was there. And pulse speculum examination showed a foul-smelling liquor, which was draining. And the PV cervix was fully dilated, membrane absent, and vertex at 0 station. And the following investigations were done. Everything is normal. Hemoglobin 10 grams per cent. Patient was taken for emergency LSCS after a high-risk concern and pediatric counseling. Twin one was a preterm baby, 1.7 kg, Apgar 410 and 710. Second baby is 1.8, Apgar 410, 710. Intraoperatively, amniotic fluid was purulent. It was in the form of thick pus, and placental bits were adherent. They were removed in piecemeal. Bilateral tubes was edematous with features of hydrosalpinx. So it was a long-standing infection actually, 3 or 4 days old. Atonic PPH she developed, and the 1.8 liters of blood loss was there, was medically managed, and persistent atonicity was present. So senior obstetrician was called and proceeded with emergency peripartum subtotal hysterectomy. And intraoperatively, patient had the bleeding, so a massive blood transfusion protocol was activated, where 1:1:1 ratio platelet, blood, and FFP were transfused, and 4 units of cryo also were given. Patient was shifted to ICU. Postoperatively, the patient had persistent high BP, started on injection labetalol and Maxel, and she was started on higher antibiotics, piperacillin and tazobactam. Hypokalemia was corrected and DVT prophylaxis was given. Postoperative day 2, the patient was extubated. All her electrolytes became normal. Postoperative period was uneventful. Blood culture showed Pseudomonas infection. Both mother and baby, they were shifted to the government institution after 2 days because they could not afford treatment in the private college. So this case, still we are with so many broad spectrum antibiotics, so much of antenatal care we have. In spite of that, we are still coming across this type of patient. So I just want your comments on this case.
What was the indication of doing CS in this patient?
Indication, because no, she is a previous cesarean, they have taken up for cesarean section.
But you said full dilatation.
Full dilatation.
We should have added clindamycin also to this patient.
Okay,
Because,
okay.
Yeah,
Right, then now still there are patients without knowing their responsibility, and we have to have more of social obstetrics to prevent these type of cases coming. We don't know what happened to her after 2 days, because she went to the government college and not followed up later. And the quality of antenatal care and patient how the second gravida and 18 years, probably whether it's a legal pregnancy or illegal pregnancy, we don't know. Whether they are getting the contraceptive needs. So still we are lagging behind that. So we have to, I don't know, socially, the obstetrics has to be addressed socially, and patients, they should come forward without any hesitation for this checkup. If she would have come for checkup, no, we could have easily given her an abortion and prevented all this equally. Okay, right. So the next case is 25 years old, gravida 3, para 2 and life 0. With 7 months pregnancy she has come. She is married 3 years. First was a preterm delivery 2 years ago. Baby weight 1.6 kg. Died on the 3rd day due to RDS. And second pregnancy after 6 months of the first. Delivered at 34 weeks, died on the 30th day due to meningitis. She was very much upset and requesting the obstetrician that she should not have a preterm delivery this time also. So, and on examination, mild anemia was there, her BMI was 30, uterus corresponded to 26 weeks, cervical length was normal, anomalies ruled out. While going through the old records, there was a urine culture report which said that GBS has been grown. Dr. Venkateshwar Rao, can she have a GBS colonization? That is, the culture report was the old one. It was the old one.
Yeah,
so the present pregnancy, I am asking whether she can have a GBS colonization.
So because she had all preterm labor, GBS may not recur continuously in different pregnancies. But she had this preterm deliveries. She is more worried.
Okay. So how we can prevent that preterm delivery?
So we can go for the prophylactic antibiotics, and because she is always going for a preterm labor.
Yeah, but cervix is normal. There is no incompetence.
Yeah. Cervix is normal.
Just 26 weeks. And the previous misshape for 33, 34 weeks.
Yeah.
Okay. So you will put a prophylactic circulage?
Prophylactic circulage is normal.
Cervix length normal, I said. So will you put a prophylactic circulage?
Because she had these preterm labors, we can go for prophylactic, but we have to take the swabs and then exclude infections.
Yes.
Then only we can go for.
Okay.
We can
So,
go for.
any other, apart from the prophylactic antibiotic, any other thing will help us to prevent the preterm labor? That is, one report has said the GBS grown. In other words, is there any role for probiotics?
Yeah, we can give the probiotics, ma'am, because to improve the colonies and then the resistance.
Okay. The question again. Yes.
Dr. Anju, shall we
tell
tell them to conclude, madam?
Yes. Yeah. She just described about the group B streptococcus. Whose question is Venkateshwar?
Yeah.
Question only.
Yeah, group B is a physiological component of the intestines or vaginal microbiome in some women. And sometimes it is present even in the reservoir in the GITs. And the prevalence of vaginal and rectal colonization in the pregnant women is about 10 to 30%. She may be having some maternal urinary tract infections or intraamniotic infections that may lead to either endometritis or preterm labor or the complications of the fetus also, stillbirth.
Yeah, so these are the problems we can
These
get
are the
when
problems
there is
which can come across.
Okay, GBS. But nowadays, no, the GBS incidence in our country is less. As Ajit mentioned, it is much less. We have done a study actually in SRM Medical College as a thesis for one postgraduate. The incidence was very, very low. Okay, right. So again, the question comes for you. How will you proceed further for this patient? And what is the chance of getting recurrent GBS and preterm delivery in this case? So you have already told you will do a prophylactic circular and give prophylactic antibiotic. And in addition, we can give her some probiotic also. Okay, so that we have to prove actually now the what is that? Dysbiosis, which we can correct by giving this lactobacillus preparations we can give and produce a normal flora of the vagina and prevent this infection. Dr. Tamil Selvi.
Madam.
Just tell us about the pathogenesis of these group B streptococcus.
Ma'am, this case is very, very difficult, madam, because there is a 30 to 40% risk of preterm labor. Actually, the GBS is a beta hemolytic streptococcus, madam. The hemolytic property is important for the infection and the immune evasion. It has to evade the genitourinary immune response for the successful colonization and infection. And other factors are also responsible for the vaginal colonization and the subsequent ascent of the bacteria. They are hemolytic pigments and the hyaluronidase enable the pathogen to resist the immune response, madam. Hemolytic pigment in the bacteria, madam, hyaluronidase. And dysregulation of this pigment can lead to bacterial clearance from the vagina. So the therapy is targeted against the dysregulation of the hemolytic pigment, madam.
Yeah, that is very important. Now they are trying to find out. So put some other microbiome inside so that will counteract the GBS. I think in Western countries, GBS incidence is a little high and they are trying on this.
Yes, madam.
Right. Yes. So how it spreads, Dr. Reshma? GBS, how it spreads? Dr. Reshma?
Not audible.
Muted. She's muted.
Unmute, ma. Unmute, ma. Reshma.
Yeah, yes, madam. Madam, women who are these vaginas are colonized by these infection. They're at a high risk of SND infection, and the newborns are also likely to get infected. It invades the amniotic cavity. The placenta also gets invaded, and chorioamnitis occurs. Inflammation of the placental membranes. which may lead to preterm labor and even fetal, probably
it is-
stillbirth and all that. Madam.
So it is similar to that of the Mycoplasma infection or other bacterial infection. Okay, nothing special about that.
Yes, madam.
And what are the risk factors, Kema, for this GBS infection?
In young maternal age patients, black race, then early or late preterm labor, patients with intraamniotic infections, maternal fever more than 100 degree, and PROM of preterm PROM more than 18 hours, and very low birth weight are risk for GBS. madam.
Okay, so our patient, the Davida 3, whether she is is a high risk patient?
Very high risk.
And in young, very high risk, madam, very high
Okay.
risk.
Okay, Kartika, how are you going to manage this lady when she comes in labor? That is a preterm labor.
So when she comes in labor, we have to take the swab, like vaginal swab for the GBS screening and start her on antibiotics. Suppose she is in threatened preterm labor and labor get arrested, then we have to discontinue the antibiotic prophylaxis, wait for the culture, and then if it is positive, we have to continue it. Otherwise, if she is in labor, then we have to continue the antibiotics until delivery.
Okay, good. So how are you going to manage her if it is PPROM?
Again, for PPRM also, you have to take a swab and start her on antibiotics. So if she is going to deliver, then you have to continue the antibiotics till delivery. If she is not entering into labor, you continue antibiotics for 48 hours. Meanwhile, you will get the culture report. So based on the culture report, you will continue the antibiotics.
In this patient, suppose the culture report is not available, whether you will give antibiotic or not. That is, culture report has come as negative. What will you do? So you will not give her a GBS antiprophylaxis.
Ma'am?
See, if this patient, in this patient, the GBS culture report comes as negative. So what will you do? And the labor has been, she is a latent. She is not continuing the labor process. It is
Then we can stop the antibiotic.
Then what else you'll do?
We can repeat the culture 4 to 5 weeks later.
Okay. Meena, how will you prevent the GBS?
So mainly giving intrapartum antibiotic prophylaxis, madam, penicillin G. When we are doing, according to the CDC recommendation, if the mother is positive with GBS screening at 35 to 37 weeks, or as in this case, history of GBS bacteriuria at any time during the current pregnancy, if it comes positive, we are doing a urine culture and it comes positive, or if there is a previous infant with GBS disease or unknown GBS status. And by giving an intrapartum antibiotic prophylaxis, the efficacy is 86 to 89%. Like preterm delivery before 37 weeks, membrane ruptured outside, that is more than 18 hours, intrapartum temperature of 100.4 or higher, or nucleic acid amplification test is positive, we have to give ampicillin 2 gram IV followed by 1 gram 4-thali. If allergic to penicillin, cephalosporins can be given, madam, 2 grams until delivery.
Okay. What is the CDC recommendation?
CDC recommends universal screening with the GBS rectovaginal swab, madam. Culture between 35 to 37 weeks in all pregnancy.
Okay, but in our part of the country, we are not doing the
We are not doing
the routine.
It is in the research only, as for PG
okay.
dissertation.
Okay. Dr. Ashok, this already you have described what is the early onset neonatal sepsis and late onset neonatal sepsis and GBS infection. The same, no, almost?
Yes, ma'am. Early onset just refers to the age of onset. So mainly that may be acquired during delivery process. So the onset of illness is within 3 days or within 1 week. If it is definitely after 1 week of life, baby's life, we take it as late onset neonatal sepsis. That GBS or maybe acquired from other hospital or other community. Yes, ma'am.
Okay. So up to 1 week it comes under early onset.
Yeah,
okay.
yes, ma'am. Yes, ma'am.
Yes. So now we have finished with the case scenario. Now to make it little interesting, I'll go for the rapid fire round. Whoever knows the answer, they can answer. Can UTI cause chorioamnionitis?
Yes.
Yes.
Yes. What is the positive nitrogen test? Just describe about the nitrogen test.
It's
Anybody? Anybody? Yes, ma'am.
test the pH. We previously were using the litmus paper, which changes color based on the presence of amniotic fluid or the urine.
So just to check the leaking of the amniotic fluid. Okay, and based on the pH.
And not done nowadays. Yes, madam.
Okay. Right. Routine screening for GBS in all pregnancies, yes or no?
No, in our country, not it.
What is the gold standard test for the PPROM?
Sterile speculum examination.
Yes. Okay. How to prevent the chorioamnionitis?
So already sir has told, avoiding multiple vaginal examination and the use of antibiotics.
In risk cases.
High risk
Okay,
cases.
right. Complications of the neonatal complications of chorioamnionitis. Neonatal
So bronchopulmonary dysplasia, cerebral palsy, necrotizing enterocolitis, a prematurity, shock, yes, ma'am.
Okay. What is the protocol for the chorioamnionitis?
Antibiotics, antibiotic, and early delivery.
Right. Okay. Antibiotic therapy and expedient delivery. Then what is the first line antibiotic? Already mentioned. Okay.
Ampicillin and gentamicin.
Gentamicin. Okay. Common bacteria in chorioamnionitis.
E. coli.
GBS.
Which mode of delivery is the best for chorioamnionitis?
Vaginal delivery.
Always?
Vaginal delivery.
This is always?
No, not always. It depends on.
Okay.
Based on the
chorioamnionitis an indication for cesarean section?
No.
No.
Can a baby survive after C-section, Dr. Ashok? Why not?
Of course. Of
Yes.
course.
Yeah. Okay. Can chorioamnionitis recur? I think we have discussed this also. There is a possibility,
But it is low.
Yeah, rate is low. Okay. They can influence the risk of recurrence and future pregnancy. Also, the risk remains low. So with this, we finish the panel. I am extremely thankful to all the panelists who have actively participated and made this discussion very lively.
Thank you, madam.
Thank you. Thank you, madam.
Thank you very much, madam.
Thank you, ma'am, for the opportunity.
Thank you. Thank you, all of you. Dr. Anju Soni, thank you very much for the opportunity given to us.
Thank you so
There-
much,
She is there.
Sakshi. Thank you very much. And it was really very well presented by you. And you can stop sharing the screen.
Huh?
Dr. Anjalakshi, you can stop sharing the screen.
Okay. Thank you. Right.
So basically, what I am saying that this is a very complex topic, and the insights shared by all of you shows your experience in practical obstetrics, and it was really thrown a lot of light on each and everything which has been covered very well by you and all the experts in the panel. And I'm sure when we will be putting this link of YouTube link for this webinar in a day or two, you should share it with all your postgraduates and colleagues. I'm sure everybody is going to get the knowledge which has been shared today, and it is so important because most of the time people just straight away go to a very higher antibiotics, which is not required per se. We have to have the antibiotic policy in our institute so that we do not give over antibiotics, and also diagnose the case, take all the cultures in time so that we can, if need be, we can escalate the antibiotics depending on whether the infection is going to is increasing by monitoring the parameters or by the report of cultures and gram stain. That will really help each and everyone. So I think we very, very well presented
Okay.
panel, and all the experts were amazing, and they really did lot of put in their experience as well as their knowledge into it. And before
Thank you.
going for thank you, I would just request everyone that I'm going for the post of Vice President. Foxy from request all dear friends to tell your friends and everyone to please support me.
Best wishes, madam.
Yeah, thank you so much. Thank you.